Very good morning, everyone. I, Dr. Rahul Agarwal. Today I have come up with a new topic of general pharmacology, that is the pharmacodynamic. Pharmacokinetic part we have already covered in the previous lectures. You can go through that in the videos. Pharmacokinetic, which was including the absorption, distribution, metabolism, and excretion. Now today we will see the pharmacodynamic part. What is pharmacodynamic? As you can see from the diagram, this diagram, the pharmacodynamic, here we will study what this is the drug is going to the body, and what the drug is doing inside the body, that we will see here in the pharmacodynamic part. Okay, so pharmacodynamic word come from pharmakon and the dynamics. Pharmakon means the drug and dynamic means the action. So what is the definition of pharmacodynamic? It's the study of effects, that is biochemical and physiological effects of drug and their mode of action inside the human's body. Or you can simply say it like what the drug does to the body. In the pharmacokinetic, we used to say what the body does to the drug, and here pharmacodynamic we say what the drug does to the body, because we will see the action of drug inside the body and how these action come, we will see that. Pharmacodynamics, in this chapter we will include what are the various study of various effects of a drug. We will see the various effects of the drug, and then mechanism of action, how the drug is acting. Mainly the drug acts via the receptor. Lock and key hypothesis was there for the receptor. Dose effect relationship, what happened with when we increase or decrease the dose in the dose effect relationship, and various factors which modify the drug effect. So now come to the basic types of drug action. So drug either can stimulate or can depress, or we have the replacement also, like for the diabetes mellitus we have the insulin, we all know. For the anemia we have the iron, and cytotoxic or anti-infective drug like anti-cancer drugs like cyclophosphamide. We'll see that in the anti-cancer part. The stimulation like adrenaline. Adrenaline stimulates the cardiac response. How adrenaline stimulates the cardiac response? So you can go through that lecture also in the video. Adrenaline acts on alpha 1, alpha 2, beta 1, beta 2 receptor. Adrenaline matlab it acts on all the receptor. So through beta 1 receptor, it stimulates the cardiac response, increase the cardiac rate. Depression, quinidine is an antiarrhythmic drug that depresses the heart. Barbiturate also depresses, barbiturates and benzodiazepine, we all know it depresses the CNS. Replacement, insulin in diabetes mellitus, and cytotoxic, cyclophosphamide, which is an anti-cancer drug that is used as an anti-cytotoxic agent. There are other cytotoxic agents also that we'll see in the anti-cancer part later on. Various mechanisms of drug action, what we have, but drug either can act by physical action. Physically the drug can act like osmotic diuretic, we used as a diuresis in diuresis part. In diuretic, osmotic diuretic, osmotic property, and bulk laxative. When the fecal matter become hard, we use the bulk laxative to increase the mass of the drug, so that the stool can easily pass out. So by physical action, these are two, diuretics and bulk laxative. By chemical action, we use the antacids for the gastric acidity. For the peptic ulcer, we use the antacids. So by chemical action, it neutralizes the gastric acid. The antacid neutralizes the gastric acid. Through enzymes, it's very important, because various drugs act by inhibiting or stimulating the enzymes. Like one is the RAS pathway, renin-angiotensin system pathway in the hypertension. That was in the hypertension. We have seen in the hypertension, and there was an enzyme called ACE, angiotensin converting enzyme. ACE is the angiotensin converting enzyme, and when we inhibit that ACE, so we act by inhibiting the ACE inhibitors like pills, enalapril, captopril, lisinoprils, all are the which act through the enzymes. Through ion channels, various channels are there like sodium, potassium, calcium. So drugs acting on these channels we call it through a drug acting on ion channels, like nifedipine, amlodipine, all the other calcium channel blockers acting on the calcium channel. So these are the different ways how the drug can act. But the important, there is another one, altering the metabolic processes. The metabolic process is there, like sulfonamide, which act by inhibiting the folic acid synthesis. So there is a pathway pteridine, PABA, glutamate, then folic acid synthesis pathway is there, or in that pathway the sulfonamide is acting, so that alters the metabolic process, and sulfonamide is an antimicrobial. But the most important part is through the receptors. This most important part is through the receptors, and through the receptors, most of the drug acts through the receptors only. So this is through the receptors. Okay, through receptors. Most of the drug acting through the receptors only. So it's a macromolecular. What is the receptor? Receptor is that site where the drug acts. So macromolecular protein site is there on the cell with which the drug binds and produce the characteristic response. So go through this diagram. This diagram is saying one is the agonist, one partial agonist, antagonist, and inverse agonist. So you can see if there is a maximal response, the maximal response produced by a drug, then it is agonist. If there is some response, then partial agonist. If no response, then antagonist. And if the response is opposite, then inverse agonist. Please don't be confused with the antagonist and inverse agonist. Antagonist is not the opposite response, it is just the not having any response. Inverse agonist is the opposite response. So see, the two terms are important, affinity and intrinsic affinity. What is affinity? Suppose in a classroom, all the students are sitting inside the class. All the students have the affinity to sit inside the class, but all the students may not have the affinity, may not have its intrinsic activity to say, sorry for the delay, may not have the intrinsic activity, may not respond properly. If the student is responding properly, giving the correct answer, then it is an agonist. If it is not responding properly, some of the answers they are giving, then it is a partial agonist. All having the affinity, but and if the student is not responding, then antagonist to your question. And if a student is responding something else, what I am asking, and he or she is responding something else, so then it is the inverse agonist. So this is like that. Agonists have the affinity, but so we'll see the definition. What is agonist? Agonist means substance bind to the receptor. It is having the affinity. Affinity is there and produce a maximal response. Maximal response when it is producing, then it is the agonist. Affinity and intrinsic activity maximum present. Means the affinity will be there for everyone, but intrinsic activity may or may not be there. So if the intrinsic activity maximum present, then it is an agonist. Example, adrenaline is an agonist and adrenergic receptor. It stimulates the adrenergic receptor, like I have told you, alpha 1, beta 1, alpha 1, alpha 2, beta 1, beta 2, all the receptors, it stimulates adrenaline. The second is antagonist. It is having the affinity, but it will not have the intrinsic activity. Bind to the receptor and prevents the. Remember, it will not have the opposite intrinsic activity. So remember, this one part has affinity but no intrinsic activity. For example, tubocurarine. Tubocurarine is the antagonist at nicotine receptors. Okay, it's a skeletal muscle relaxant antagonist at nicotinic receptors. Partial agonist will again have the affinity, but it will have the some intrinsic activity, but not the maximum intrinsic activity. Like pentazocine, which is an opioid, is a partial agonist at mu opioid receptor. Opioid receptors have different subtypes, mu, kappa, delta. So pentazocine is partial agonist at mu opioid receptors. Inverse agonist. Now here is the inverse agonist. It is different from antagonist. Inverse agonist has the opposite response, opposite to that produced by the pure agonist. Like beta carbolin, which is an inverse agonist of diazepam, bind to the benzodiazepine receptors. So beta carbolin is an inverse agonist of diazepam. Okay. So two another terms, potency and efficacy. Like we have discussed about the affinity, intrinsic activity, but now come to the potency and efficacy. P for one mnemonic you have to remember: P for potency, P for potency, and P for power. P for potency and P for power. So PP, potency means power. Remember this one, potency means power, and E for efficacy, and E for efficacy, and E for effect. E for efficacy, E for effect. Potency means power. What is the definition of potency? It is the amount of a drug needed for evolving a response. How much the drug you are giving to gain a response. Okay, I am getting the response with 10 milligram. I am getting the response with 20 milligram. What will be, is the 10 milligram will have more potency than 20 milligram, or 20 milligram will have more potency? So correct. It's a 10 milligram which will have the more potency. So we say when you are giving the less dose and you are getting the effect, then it is more potent than the another one. Efficacy is the maximal response. We'll see in the graph, one very nice graph is there. Efficacy is the maximal response, the response which is generated, which is produced by a drug. So this is the difference between potency and efficacy. This is very important for your exam point of view also. So this is the graph. So we say the efficacy by demonstrating this line. This is the dose effect relationship. Efficacy is the maximum effect. Maximum effect is this one. Maximum effect is this one. The efficacy is the maximum effect. And potency we say with the dose. जिसकी कम डोज से response आएगा, that will have the more potency. Okay. Now we compare. This is the drug A and this is the drug B. So which will have the more potency? The response is coming. Drug A response is coming with the less dose. So drug A will have more potency than drug B. And which will have the more efficacy? Drug A will have the more efficacy than drug B. Now compare with the drug C. Among drug A and drug C, which will have the more potency? Drug A will have the more potency because the curve, ऐसे remember कर लीजिए, the curve more curve towards the left side, more will be the potency. More curve towards the right side, less will be the potency. And drug A and drug C, which will have the more efficacy? Yes, both the drug A and the drug C will have the equal efficacy. It is coming to the same line, so it will have the equal efficacy. And among the drug B and drug C, which will have the more efficacy? Drug C is more efficacy than having more efficacy than drug B. So this was I am telling you about potency. Drug A greater than drug B, then greater than drug C. Obviously, more towards the left side, more will be the potency. And efficacy, drug A equals to drug C, same, and drug B has the least efficacy. This was I was trying to explain you. Another important concept is the therapeutic index. What is therapeutic index? It is the margin of safety of the drug. Just remember the margin of the safety of the drug that exists between the dose of a drug that produces the desired effect in 50% of the population and the dose that produces adverse effect in 50% of the population. So we see the desired effect in 50% of the population, and we see the adverse effect in 50% of the population. So we see here by plotting this graph, and this is the desired effect and this is the adverse effect. If you go beyond this, then adverse effect will start. If your dose, this is the dose and this is the response. If your dose will be in between this, there will be no adverse effect. If your dose will go beyond this, it will be having the more adverse effect. So suppose therapeutic index is like this. If we decrease the therapeutic index like this, okay, so slight increase in the dose will increase your adverse effect also. So therapeutic index is wider. If the therapeutic index is wider, then the drug will be more safe, or therapeutic index is less wider, then the drug will be more safe. If the therapeutic index is more wider, then the drug will be more safer, because you can increase the dose of the drug if there is a more therapeutic index. अगर therapeutic index कम हुआ, तो slight increase अगर आप dose करेंगे, तो it will increase the chances of adverse effect also. So we measure here by this is the effective dose ED50 and this is the lethal dose LD50. So there is an equation for this therapeutic index to measure LD50 upon ED50. LD50 upon ED50, and in human we say the TD50 upon ED50. So narrow therapeutic index drugs is important to remember, because these are the drugs which will be requiring the plasma level monitoring, because it's a narrow therapeutic index. Slight increase in the dose will cause the adverse effect in the patient. So remember the some important narrow therapeutic index drugs: lithium, warfarin, dioxin, barbiturates, cyclosporin, phenytoin. And large therapeutic index antibiotics mostly having the large therapeutic index: penicillin, diazepam, atenolol. Lithium and warfarin is very important. So remember that the narrow therapeutic is having the narrow therapeutic index. So it will require the therapeutic drug monitoring, or we call as the plasma concentration level is monitored before changing the dose. Okay. Now this now we will see the receptors. The drug mainly acts through the receptors, like lock and key hypothesis we have seen. Like there is a lock, and for that lock there is a specific key. So lock and key hypothesis is there. So we classify the receptors based on the signal transduction mechanism. When the drug binds to the receptor, now after that what? Drug bind to the receptor, then there are certain things which goes on inside the cell that will produce the mechanism. So we will see that. First is the ligand gated ion channel. Ligand gated ion channel, which is also called as inotropic receptor. So it is the fastest acting, like you have seen in the metro. When we put the coin in the gate, outside the gate, so then automatically the gate opens very fast. So it is the fastest acting, like that only it is. When the drug came to the receptor, the channel opens and ions move inside. So it is the fastest acting. Special gates are there just like in metro, and examples of example of that is GABA receptor, NMDA receptor, NM receptor, NM receptor. Why it is important? Because we get the response very quick. We get the response very quick here. The drug, when it is bind to the receptor, we get the response very quick. Hyperpolarization or depolarization, we get the response very quickly. Second is the G protein coupled receptor, GPCR. The drug bind to this, G protein activation is there, generate some second messengers, and that activate the signal cascade later on. So G protein receptors, if we go detail into that, it's having the alpha, beta and gamma subunit binded to the GDP. When the ligand bind to the receptor, this dissociate, GDP converts into the GTP, alpha dissociate, alpha अलग हो जाता है, gamma beta अलग हो जाता है, and this will produce the response. Now this alpha activated alpha जो है वो that will produce the response. So most of the drug follows the GPCR, maximum GPCR ही है. Adrenergic drug or cholinergic drug, that works through the GPCR only. Third is the enzymatic through tyrosine kinase. The enzymes here are present inside the cell. Inside the cell, the enzymes are present. When the drug bind, this enzyme get activated, tyrosine kinase, phosphorylation of tyrosine kinase, key signaling molecule, and then activate the cell signaling. So what are the various drugs which act through tyrosine kinase? So remember, with the pig, prolactin, insulin and growth hormone, these drugs act through the tyrosine kinase receptors. Okay. The fourth one is the intracellular receptor. Intracellular receptor means inside the cell. Inside the cell, either in the cytoplasm or in the nucleus. Either in the cytoplasm or in the nucleus. So intracellular receptor, in the cytoplasm we have the corticosteroid and vitamin D. So corticosteroid and vitamin D, we have the mnemonic cytoplasm. Inside the cytoplasm में CD. Inside the cytoplasm, remember with the CD, corticosteroid and vitamin D. One is the corticosteroid, one is the vitamin D. And in the nuclear receptor, we have the testosterone, estrogen, progesterone, thyroid, vitamin A. These are the nuclear receptors. Okay. So drug act through these receptors here, means it's acting inside the nucleus and inside the cytoplasm. Okay. So antagonism. Now coming to the antagonism, various types of antagonists are there. When the effect of a drug is less than the sum of the effect of the individual drug. So it means there is some antagonism: physical antagonism, chemical antagonism, physiological and pharmacological. So these are the four types of antagonism. In the physical antagonism, like the activated charcoal is there, which absorbs the alkaloid. This is the example of physical antagonism, charcoal. Chemical antagonism, we have seen the antacid, which we give for the peptic ulcer. Neutralization of gastric acid by any of the antacid like aluminum hydroxide, magnesium hydroxide or sodium bicarbonate. So we have the antacids for which neutralizes the gastric acid. This is the example of chemical antagonism. Physiological or functional antagonism. Physiological antagonism. What is physiological antagonism? When two agonists acting at different receptor counterbalance each other by producing opposite effect on the same physiological system. दो एगोनिस्ट है, बट इट इज एक्टिंग ऑन द डिफरेंट रिसेप्टर. जब एक एग्जांपल के साथ देखते हैं तो समझ में आ जाएगा. एड्रेनालिन इज अ फिजियोलॉजिकल एंटागोनिस्ट ऑफ हिस्टामिन इन ब्रोंकियल मसल. व्हाट इज दिस? एड्रेनालिन एक्ट्स ऑन अल्फा 1, अल्फा 2, बीटा 1, बीटा 2 रिसेप्टर. ठीक है. Histamine but does not act on this alpha 1, alpha 2, beta 1. Histamine acts to H1, H2, H3 receptor. We know that. But Adrenaline by acting through beta 2 receptor, it will dilate the bronchus and it will cause the bronchodilation. Okay, but histamine causes the bronchoconstriction. So that's why both are the physiological antagonists acting on different receptor. Adrenaline is acting on another receptor, one receptor, beta 2. Histamine is acting on H1 H2 receptor, that is the histamine receptors. So that is why these are both are the physiological antagonists of each other, and having the different effect. One is the bronchoconstrictor and one is the bronchodilator. Histamine is the bronchoconstrictor, adrenaline is the bronchodilator. So that's why we call it when two agonists acting at different receptor पे act कर रहा है, adrenaline histamine counterbalance each other. One is producing bronchodilation, one is producing bronchoconstriction, producing opposite effect on the same physiological system, but producing the opposite effect. Okay. Now come to the pharmacological antagonist. Pharmacological antagonist. Now here the receptor is same. वहाँ पे receptor अलग थे. Physical antagonist. Physiological में receptor was the same. यहाँ the receptor is the opposite. Receptor here the receptor is the same. Acting on the same receptor to produce the opposite effect. Opposite effect है receptor same है. Like beta blocker, beta agonist. Atenolol is a pharmacological antagonist of adrenaline. Adrenaline is acting on alpha 1, alpha 2, beta 1 and beta 2. And atenolol is a beta blocker. Adrenaline is acting on alpha 1, alpha 2, beta 1, beta 2. And जो atenolol है आपका, it is a beta blocker. It is acting on beta receptor. So atenolol is a beta blocker. It is acting on beta receptor. The receptor antagonists are selective, often lead to profound pharmacological effect. Receptor antagonists are of two types. One is the competitive and one is the non-competitive. ठीक है? Okay. Now coming to the another topic of discussion, that is the what happens when you combine the two drugs. When you combine the two drugs, either it can be called addition or summation, either it can be called synergism, either it can be called potentiation, or either it can be called antagonism. So we'll see that there is some slight differences are there between the addition or summation, synergism, potentiation and antagonism. Addition or summation, this is simple. We know from our math 2 plus 2 is equal to 4. 2 plus 2 is equal to 4. When two drugs are combined, it should have the effect 4, algebraic sum of their individual effect. Like combi flame plus, it is having the two drugs, ibuprofen and paracetamol, both is inhibiting the prostaglandin synthesis. So we get the analgesia from both the drug. So when we combine the drug, it will have the more analgesia part. So we generally give, if the severe headache is there, so we give the combi flame plus. This is the example of addition summation. Synergism. There are some drugs where we follow where the synergism pattern is followed. Why? 2 plus 2 should not be equal to 10. It should be equal to 4 only. But there are some drugs where 2 plus 2 is equal to 10. The combined effect is more than the greater than the algebraic sum of their individual effect. For example, this cotrimoxazole. Cotrimoxazole, it is having the two parts, trimethoprim and sulfamethoxazole. There are two drugs in cotrimoxazole, one trimethoprim, one sulfamethoxazole. Why 2 plus 2 is now we have become the 10? The reason is trimethoprim and sulfamethoxazole both are the bacteriostatic drug. Both are the bacteriostatic. When you combine two drugs together, it will become the bactericidal. Why? Because one drug is blocking this step, one drug is blocking this step. When you block the entire step, this will become the bactericidal and no DNA will be synthesized. So the combination is bactericidal, but the individual drug is bacteriostatic. That's why 2 plus 2 is equal to 10. Third, the potentiation. Potentiation, we will also see potentiation also with the help of with the help of diagram, with the help of example. 2 plus 0 is equal to 5. How this is happening? 2 plus 0 is equal to 5. Means you are giving one drug which is active and one drug which is inactive. One drug is active, one drug is inactive. It is having the 0 effect. But then also the second drug is increasing the effect of the first drug. How we coming this? Levodopa and carbidopa example. We know that we give the levodopa and carbidopa in Parkinsonism. Carbidopa has no role. Levodopa has role. Levodopa has role. It's increase the dopamine level in the brain. Where dopamine should be increased, it should be increased in the brain. But we give levodopa through oral route. So dopamine cannot enter into the brain. Dopamine cannot enter into the brain. So how we are giving this levodopa will not enter into the brain. It will not give carbidopa. So that's why carbidopa is only helping levodopa to enter into the brain and further enter into the dopamine. Carbidopa inhibits this dopa decarboxylase enzyme. So that's why levodopa enters into the brain in large amount, will release the dopamine. So that's why 2 plus 0 is equal to 5. Thank you very much.